With Campylobacter jejuni, campylo means curved, bacter means rod, while jejuni refers to the jejunum, which is a segment of the small intestine found between the duodenum and the ileum. So Campylobacter jejuni is a comma-shaped bacteria, and it's one of the most common causes of bacterial gastroenteritis worldwide. It's commonly found in foods like poultry and unpasteurized milk. Now let's talk microbe anatomy and physiology. Campylobacter jejuni is a comma-shaped bacteria that has a thin peptidoglycan cell wall, which doesn't take in the purple dye when gram-stained and instead appears pink or red, which makes it a gram-negative bacteria. It also has a flagellum at one end which it uses to get around, so it's a motile bacteria. In addition to this, it's oxidase positive, meaning that it can use oxygen to create stored energy or ATP. Lastly, Campylobacter jejuni is a microaerophile that loves warmth, so it grows best in low oxygen environments at 42 degrees Celsius on blood agar varieties like Skiro, Butzler, and Campybap. Alright, Campylobacter jejuni is usually transmitted from animals to humans via the fecal-oral route. In other words, you catch it by ingesting stool particles containing the bacteria. Campylobacter jejuni usually resides in the gastrointestinal tract of birds. So when people eat raw and undercooked poultry, there's a possibility of infection. Similarly, cows are common carriers, so people that drink unpasteurized milk can also risk infection. There's also direct contact with infected pets, notably puppies, which excrete the bacteria in their stool. Kids are the most susceptible to getting infected after playing with an infected pet. Lastly, infected stool can end up in sources of fresh water, like rivers, and cause infection. Once inside our body, Campylobacter jejuni has a number of virulence factors that it can use to attach to host cells and cause disease. First, it has fimbriae-like filaments and cell surface proteins like PEB1 and CADF that help it attach to the mucosa of the small intestine and colon. There, Campylobacter jejuni uses its spiral shape and long flagella to drill into the mucosa where they release toxins called cytolethal distending toxins. These toxins damage nearby intestinal epithelial cells, further worsening the inflammation. When the inflammation and damage become pretty extensive, the colon might dilate, resulting in toxic megacolon. The bacteria can also keep drilling until they reach the bloodstream, causing bacteremia. The immune system may react to the presence of bacteria in the blood by making anti-ganglioside antibodies, which attack the peripheral nerves, causing Guillain-Barré syndrome, a type of paralysis. Similarly, the infection can also cause an autoimmune inflammatory reaction, where immune cells attack the joints in a condition called reactive arthritis. Symptoms usually show up after a 1 to 7 day incubation period. Typically, people have symptoms like fever, muscle pain, malaise, and headache, which are followed by crampy abdominal pain and diarrhea that is watery and ill-smelling at first and then turns bloody. Bloody diarrhea is more commonly seen in children. Additional symptoms may appear with complications. With toxic megacolon, there's bloating, tachycardia, and possible loss of bowel sounds on physical examination. With Guillain-Barré syndrome, there's ascending paralysis, meaning it starts at the feet and then extends to the upper body. Campylobacter jejuni infection is actually one of the most common bacterial causes of Guillain-Barré syndrome. Lastly, with reactive arthritis, there's pain in large joints. Campylobacter jejuni infection is diagnosed based on clinical manifestations plus direct examination of a stool sample, which shows gram-negative, comma-shaped bacteria and also white and red blood cells in the stool, or by isolating the bacteria on cultures. Now, since the infection usually resolves on its own, treatment usually relies on hydration and correcting any electrolyte imbalances that may occur as a result of diarrhea and vomiting. With severe infection, antibiotics like erythromycin can be used. Finally, means for preventing transmission in humans are hand washing, thoroughly cooking meat, especially poultry, keeping raw meat, specifically poultry, separate from other foods, and lastly, don't drink raw or unpasteurized milk. Alright, as a quick recap, Campylobacter jejuni is a comma-shaped, gram-negative, oxidase-positive bacteria found mostly in poultry and unpasteurized milk. It grows best on Skiro, Butzler, and Campybap blood agars at 42 degrees Celsius in low oxygen environments. It's responsible for causing gastroenteritis, and symptoms include bloody diarrhea, fever, crampy abdominal pain, and vomiting. Some worthy complications to mention are toxic megacolon, Guillain-Barré syndrome, and reactive arthritis.
Helicobacter pylori, or H. pylori for short, is a bacterium found in the stomach of over half of the world's population. In some individuals, it can cause inflammation of the stomach lining and can result in peptic ulcers. In fact, complications from H. pylori ulcers is thought to have been the cause of death for the famous writer James Joyce. H. pylori is a gram-negative bacteria that's shaped like a curved rod, and it has 2 to 6 flagella, kind of like multiple tails, all at one end, which it uses for movement. It's positive for urease, oxidase, and catalase, and is a microaerophile, so that means it needs oxygen to survive but requires less than the levels typically found in the atmosphere. Now, in the stomach, there are 4 regions: the cardia, the fundus, the body, and the pylorus. And the pylorus itself is made up of 2 main parts, the antrum and the pyloric canal, which connects to the first section of the small intestines called the duodenum. Okay, now normally, the inner wall of the entire gastrointestinal tract is lined with mucosa, which consists of 3 cell layers. The innermost layer is the epithelial layer, and it absorbs and secretes mucus and digestive enzymes. The middle layer is the lamina propria, and it has blood and lymph vessels. The outermost layer of the mucosa is the muscularis mucosa, and it's a layer of smooth muscle that contracts and helps with the breakdown of food. The epithelial layer dips down below the surface of the stomach lining to form gastric pits, and these pits are contiguous with the gastric glands below, which contain various epithelial cell types, each secreting a variety of substances. So, for example, foveolar cells, or surface mucus cells, secrete mucus, which is a mix of water and glycoproteins that coats the stomach epithelial cells. With all these digestive enzymes and hydrochloric acid floating around, the stomach and duodenal mucosa would get digested if not for this mucus, which coats and protects the epithelial cells. Within the glands, particularly in the body and fundus of the stomach, are parietal cells, which secrete hydrochloric acid to help maintain the acidic pH in the stomach. There are also chief cells that secrete pepsinogen to digest proteins, and then there are G cells which secrete gastrin, which has a number of effects, including stimulation to parietal cells. An H. pylori infection is thought to spread through fecal-oral, gastro-oral, and perhaps oral-oral transmission from one infected individual to another. That is, through contamination of food and water, or even directly with fecal matter, vomitus, or saliva. However it makes its way into the body, once it arrives within the stomach, H. pylori uses its flagella to propel towards the stomach lining. Typically, it will migrate to regions where pH is less acidic, like the antrum, which has fewer parietal cells. It then uses adhesion proteins to stick to the surface of foveolar cells, where it can release a number of virulence factors which help it both survive and thrive and cause damage to the mucosa. One of the most important enzymes for their survival is urease, because it converts urea in the gastric juices to carbon dioxide and ammonia. Ammonia, which is basic, locally neutralizes the acid gastric environment and protects H. pylori from the harsh acidic environment of the stomach. While H. pylori itself does not typically go inside the epithelial cells, some of the virulence factors it releases do, and they cause excessive damage to epithelial cells. For example, some strains of H. pylori produce cytotoxin-associated gene A, or CAG-A, which interferes with the attachments between epithelial cells that normally protect the underlying mucosal layers. That induces an inflammatory immune response within the gastric lining, called gastritis, as mononuclear immune cells become attracted to the infection site. In chronic infections, CAG-A has been linked to the development of 2 gastric cancers, mucosa-associated lymphoid tissue, or MALT lymphoma, which involves B cells, and adenocarcinoma, which involves cells within the gastric glands. Some strains of H. pylori produce exotoxin vacuolating cytotoxin A, or VAC-A, which causes epithelial cell death and exposes the underlying mucosal layers to gastric acid. As more and more cell layers die, deep holes through the mucosa form, called ulcers. Now, inflammation also stimulates the G cells to secrete gastrin, which in turn stimulates parietal cells to produce even more hydrochloric acid. And all this excess acid can spur the formation of both gastric ulcers and duodenal ulcers, the main distinction being the exact location of the gastritis. Antral gastritis leads to duodenal ulcers, whereas corpus gastritis leads to gastric ulcers. Very deep ulcers can erode underlying blood vessels and may even erode all the way through the wall of the stomach, or duodenum in particular, causing a perforation. Finally, and very rarely, long-standing duodenal ulcers in the pyloric canal can sometimes have so much edema or scarring that they obstruct the normal passage of gastric contents into the duodenum. The majority of individuals with H. pylori don't have any symptoms, and it may play an important role in the natural stomach ecology. But in some individuals, there can be chronic infection, particularly with strains that have CAG-A or VAC-A. That can cause symptoms like heartburn, shortness of breath, and loss of appetite with or without weight loss, and pain in the abdomen just above the stomach that worsens a few hours after eating. Ulcers that lead to blood vessel erosions may cause bleeding, and blood in vomit or feces. If a nearby artery is eroded, it could lead to rapid blood loss and shock. If a perforation occurs, air can collect under the diaphragm, irritating the phrenic nerve and sending referred pain up to the shoulder. Finally, a chronic infection can also lead to iron deficiency anemia. It's thought that these bacteria sequester dietary iron, literally eating it before you can get to it. There are a few ways to diagnose H. pylori infection. A fecal antigen test, blood titers, or a urease breath test with labeled urea can be used to detect the bacteria or enzymes. Lastly, upper gastrointestinal endoscopy can be used to get a gastric biopsy. Finally, a diagnosis can be made by culturing H. pylori from a gastric biopsy. Without the presence of clinical symptoms, H. pylori is not typically treated. But if it's detected in a person with a family history of gastrointestinal cancers, or when clinical symptoms are present, triple therapy is effective and consists of 2 antibiotics, typically amoxicillin and clarithromycin, and a proton pump inhibitor. So, to recap, Helicobacter pylori is a gram-negative microaerophilic bacterium commonly found in the stomach. The majority of individuals infected with the bacterium are asymptomatic, and it may play an important role in the natural stomach ecology. It's linked to the development of gastric and duodenal ulcers, malt lymphomas, and gastric cancer. Acute infection may appear as an acute gastritis with abdominal pain or nausea. Treatment includes antibiotics and a proton pump inhibitor.
Cholera is a contagious infection caused by the bacteria Vibrio cholerae, which can in turn cause severe gastroenteritis and excessive watery diarrhea for several days. Rapid dehydration and electrolyte imbalances can be fatal, as suspected in the deaths of James K. Polk, the 11th President of the United States, and Charles X, the King of France. V. cholerae is a gram-negative curved bacteria which looks like little red or pink comma shapes on a gram stain. It's positive for oxidase and grows in alkaline media. It has pili and a single polar flagellum, kind of like a tail at one end, which it uses for movement through the gastrointestinal tract. It's a facultative anaerobe, so that means it can undergo respiratory and fermentative metabolism. Transmission of V. cholerae typically occurs through a fecal to oral route. This includes consuming untreated sewage water and anything that comes in contact with it, like raw or undercooked fish, including shellfish, and improper hygiene, like a lack of hand washing after a bowel movement. Cholera tends to be more common in developing countries and places lacking advanced sanitation and sewage treatment facilities, with high rates in some locations in Africa and South America. People who have low gastric acidity or have an O blood type are particularly at risk for a severe infection. Now, when V. cholerae enters the stomach, it shuts down protein production to conserve energy and nutrients, and to survive the acidic environment. But once V. cholerae is in the intestines, it uses its flagella to move towards the intestinal walls, propel through the mucus layer on top of the epithelial cells lining the intestines, and attach to the finger-like cellular projections called villi on the surface of the epithelial cells. There, V. cholerae can begin to multiply and produce toxins. And though V. cholerae does not enter the epithelial cells itself, the toxins do, and they can cause a lot of trouble. Now, the exact toxins produced can depend on the strain of V. cholerae. Some strains produce toxins that won't cause any or maybe just mild clinical symptoms. But some strains produce cholera enterotoxin, also called choleragen, which is most often the cause of significant clinical symptoms. When cholera enterotoxin enters the epithelial cells, it leads to the ADP ribosylation of the GS alpha subunit of the G protein. So this causes the G protein to become permanently activated, and it keeps activating a membrane-bound protein called adenylate cyclase. This protein in turn leads to an overproduction of the intracellular secondary messenger protein cyclic adenosine monophosphate, or simply CAMP. An increase in CAMP causes chloride channels on the cells to increase the secretion of chloride into the lumen, while inhibiting the channels that let sodium and chloride back into the cell. So the abnormally high levels of luminal sodium and chloride disrupt the osmotic balance between the intestines and the surrounding tissue, and water, bicarbonate, and potassium rush into the lumen of the intestines as a result. All of this can cause symptoms like vomiting and voluminous amounts of watery diarrhea containing extremely high concentrations of sodium, potassium, chloride, and bicarbonate, as well as high levels of live V. cholerae ready to infect another individual. There could also be flecks of the mucus layer of the intestine which looks similar to rice in water. Typically, there is no fever, pain, or cramping. And while the incubation time for V. cholerae can take hours to 2 to 3 days, severe dehydration and depletion of electrolytes can happen within 4 to 12 hours of the first bout of diarrhea or vomiting. These imbalances can lead to symptoms like disorientation, dry mouth, swollen tongue, sunken eyes, cold clammy skin, or shriveled and dry hands and feet. Other, even more severe, fatal complications can come from depleted electrolytes and water in the blood. Like low levels of bicarbonate can cause metabolic acidosis with deep and labored breathing, called Kussmaul breathing. Or low levels of potassium can cause muscle dysfunction, including leg cramps, weakness, and abnormal heart rhythms. And low chloride and sodium can cause headaches, poor balance, disorientation, seizures, and coma. Finally, severe dehydration can cause hypovolemic shock with a significant decrease in blood pressure. Diagnosis is typically made by a stool sample growing V. cholerae on a thiosulfate, citrate, bile salt, sucrose agar. But even before a definitive diagnosis can typically be made, the first line of treatment is to rapidly replace the lost water and electrolytes with rehydration salts either orally or intravenously. In cases of mild to moderate diarrhea, this type of supportive therapy is enough of a treatment course, and the diarrhea may resolve on its own in about 3 to 7 days. But more extreme cases may require antibiotics. In this case, the stool culture can be helpful in deciding which antibiotics would be most effective against the infecting strain, and may include tetracyclines, ciprofloxacin, ofloxacin, furazolidone, or trimethoprim sulfamethoxazole. So, to recap, cholera is a contagious, severe gastroenteritis caused by the gram-negative Vibrio cholerae bacteria. Its route of transmission is fecal to oral through consumption of contaminated sources like water or shellfish. Some strains produce cholera enterotoxin at the surface of intestinal epithelial cells, which leads to the overactivation of CAMP by permanently activating GS-alpha. Patients most often present with voluminous rice water diarrhea that quickly leads to dehydration and electrolyte imbalances that can be fatal if not rapidly treated with rehydration salts.